All right. So first, I'd like to thank you all for coming to see my capstone presentation. I worked pretty hard on this, so I'm glad I'm able to share it with you all. So my name is Tanya. I'm a nursing student with the Nursing Informatics program here at Grantham. My goal eventually with my informatics degree is to hopefully be able to bridge the gap between the technology part of healthcare and the clinical part of healthcare. When I was working on my capstone, one of my goals was with this capstone is I knew once I finished my degree, I would no longer be in the office setting that I'm in. So my goal was to leave the office with something that they could use in the future after I moved on to the next chapter in my career. So in primary care, which is the type of setting I work in, many number of primary care providers are caring for patients with chronic conditions. One of the chronic conditions that we're seeing an increase in is diabetes. When a patient has diabetes, they require numerous amount of test results and continuous follow-up. The goal of my capstone project was to create a dashboard that the primary care practice can abstract the data from the electronic medical records that would identify the patients within the practice that have an elevated A1C or patients that have not had a current A1C within the calendar year. In the future, the goal of this project would be able to decrease the A1Cs of these patients and improve patient care by using the dashboard information in the diabetic patients in primary care. This slide shows the program outcome of I5 quality improvement. So the little bit of background is primary care providers have seen an increase in the number of diabetic patients within their patient panel. Due to the increase of patients in this patient panel, the number of labs that they are ordering on their patients has increased. And along with that increase is the number of results that need to be verified by each provider on a daily basis. When you increase the number of labs and increase the number of results that need to be verified, there is an increase in the possibility of missed follow-ups with these diabetic patients. This slide shows program outcome C2 critical thinking. Over the past years, the number of diabetic patients that have been followed by a primary care provider has increased. These patients need to have continuous monitoring of blood work. Their A1C should be checked every 3 to 6 months. Then these lab results are transmitted to the electronic medical record. The healthcare provider needs to verify these results and then document a follow-up plan for these patients. In addition to the medical doctor or the nurse practitioner, primary care nurses also play a significant role in the care plans and interventions of these diabetic patients. A significant decrease is noted in the hemoglobin A1C and an increase in scheduled follow-up when a patient receives nursing intervention. This slide here shows program outcome C4, collaboration and teamwork. In my review, alert fatigue is a problem when providers are receiving multiple alerts throughout the day, whether it's lab results that need to be verified or triage tasks that need to be reviewed. It could be overwhelming for the provider. 86% of clinicians state that alert fatigue is extreme and lab work follow-up could be perceived more than the clinician could accomplish effectively. Delays in receiving results and verifying these results can result in delay of treatment, which can lead to poor outcomes for these patients. Electronic medical records at this time do not alert providers when their patients have not had a follow-up test order. Workarounds are bypassing the inconvenience of a challenging program. If something is too hard or takes too much time, a provider may use a workaround. Approximately 43% of clinicians have used a workaround in electronic medical record to follow up on test results. And over 70% of those workarounds come in a form of paper, such as a list, a sticky note, a printout, or a fax. This slide shows program outcome C2, critical thinking, and C5, evidence-based practice. The current practice that I work in does not have a streamlined technology-driven program to receive data from the electronic medical records. Currently, the hemoglobin A1C is manually entered into a spreadsheet after verification of the provider to monitor the patient. Unfortunately, lab results can be overlooked and follow-up can be missed. A study has shown that 28% to 55% of test results in family practice electronic medical records do not have any documented follow-up. With no follow-up plan, a patient with elevated hemoglobin A1Cs can go for an extended period of time without tracking or monitoring. This slide shows program outcome C3, patient-centered care. The purpose of my Capstone project is to create a process, such as a data platform, to gather data from the electronic medical records to accurately find patients with a hemoglobin A1C greater than 9%. A normal A1C is 5.4 to 6.4. So you may ask, why did I not choose 6.4 as my number? We chose the identifier of 9% was because it was depending on comorbidities and age, some factors, some other factors. The provider may be okay with an A1C of 7 or 8. It can depend on the patient. When the patient A1C becomes greater than 9%, other risk factors may become involved. So another purpose was to fill the gaps of care. A patient without an A1C in the current calendar year could be going without care. The future goal for my project is to be able to provide self-management support through our care management team to these patients that we've noticed on these reports. This slide shows program outcome I1 and C6 professionalism and I5 quality improvement. The theoretical framework for my project was the technology acceptance model. Technology is used to improve quality care in healthcare sector by enhancing patient safety, staff efficiencies and effectiveness, and reducing organizational expenses. The technology acceptance model looks at the individual behavior regarding new technology and how the technology will be integrated by the user. Many people can see technology as cumbersome and more work than help. The goal of this project is to show that technology can ease the provider's workload and promote quality care for the patients in their practice. This slide shows program outcome C5, evidence-based practice. I was able to work with Acuitas Health, who is a third-party vendor, by using their platform called Population Health Builder. I was then able to create a dashboard by extracting data from our electronic medical records to look for patients with a hemoglobin A1C of greater than 9 or who did not have a current A1C in the calendar year. My goal for this project is to be able to decrease the patients to an A1C less than 9 and be able to decrease the gaps in care to be able to get those patients who have not had a current A1C to have one in the year. This slide shows program outcome I5 quality improvement and I2 patient-centered care. The significance of my project is to help improve practice workflow, to be able to improve patient safety and quality care to the patients that have diabetes within the practice. The dashboard will also allow pharmacists and care managers to better understand patients who may require their services, such as self-management support and pharmacy interventions. I had multiple participants to help within this project. I was the project leader who worked with Acuitas Health to build the dashboard using their platform. I also had other participants, such as a pharmacist, a care manager, and some medical staff, the nurse practitioner, a medical doctor, and a nurse within the practice. This slide shows program outcome C4, collaboration and teamwork. When I was reviewing my dashboard in my project, there was a few assumptions that came up. The first assumption would be that the participants within the program would use the dashboard. The hope is once you put in the work, you would hope that somebody would use it. At the end of the use of it, I administered a survey. My goal and assumption was hopefully that they would be honest on the survey on how they use the information. Another assumption during this project was that the information that was received in the dashboard was going to be accurate information. There was a few limitations when it came to this. The number that was used for a cutoff for A1C of 9%, that can limit the amount of patients that you work with. The number of practices within my project, I only had one practice that I was currently using. We also found that one of the limitations that happened within the project was the patients who use specialists for their lab work. And I'll discuss that a little bit later on. Also, a limitation was the number of people that were using the dashboard, as there was only 5. For ethical assurance, all information was confidential. I have some slides later on, but all information of the patient has been removed. The A1C is the only reason for segregation. We did not look at gender. We did not look at area code. We did not look at anything else but A1C. And our goal is to provide self and quality care for these patients. This slide meets program C1 diversity, C4 diversity, and I3 safety. So the implementation of my project plan. Population Builder is a platform through Acutus Health by which the diabetic dashboard was built. The platform allowed me to gather data from the electronic health record and create a spreadsheet with demographic information of the patient population. The patients with an A1C of greater than 9 were gathered, and then secondary, I pulled patients that did not have an A1C in the current calendar year. In addition, I worked with our IT department to build what we call a J drive to allow access to members of the care team to access the same information. The information will be updated as each member works on the spreadsheet, but does not allow for duplication of work, where only one person can be in the program at a time. Once that is saved and the person gets out, the next person can get in and see what the previous person has used. This slide shows program outcome I1 professionalism, I5 quality improvement, and C4 collaboration and teamwork. So let's get into what I built. So this is the dashboard that I created. So we used the program Population Builder. Population Builder is used for the whole organization that I work for. There's multiple practices within the organization. So if you look at the top, the organization has 1.29 million people within the organization. So I had to break that down. I could not work with a 1.29 million people. So I was able to pull in this patient filter here to apply the filter. So when I applied the filter, I asked for patients that were alive. I also wanted patients who were that were seen in the primary care setting that I work in. And I was also looking for patients that were seen in the last 2 years. Because if they were seen in the last year, their A1C may not be overdue. So I wanted to look, kind of get a nice roundabout number so in the past 2 years. So that was able to bring me down to 11,252, still a large number to work with. So then I was able to bring in this problem list, which allowed me to bring in all 508 ICD-10 codes that were used within the organization for diabetes. Now, this could be diabetes with complications, diabetes without complications, diabetes with neuropathy or nephropathy, or any kind of diabetic code that is used in a diabetic patient. So I was able to pull that in. Then it brought me in to see that I had 1,327 patients within my practice who have some type of diabetic code. Lastly, on this here, I showed that I brought in the lab filter. For this lab filter, I brought in the 16 codes that were used for A1Cs within the organization. Some parts use a self test at the office. Sometimes we send it out to the lab. So this was able to bring in all 16 possible results that were used for the laboratory filter. And then I wanted to apply that at least the number was at least 9 or greater. So once I applied those filters, I had 359 patients who are seen within the practice in the past 2 years, who are alive, who have a diabetic code within their ICD problem list and have an A1C of greater than 9. I then applied the same filters later on and changed the lab filters so that I had it so that they did not have a current A1C in the calendar year. So I changed the lab filters just a little bit. This here shows some of the filters that I use when I get into the table, which will be on the next slide. I was able to choose what I wanted to be shown on the table. These are the information that's brought in when I put in that patient filter. This allows me to select anything I want to see of the patient. As I said, I didn't really want to separate by gender or race or ethnicity, so I only wanted their separation to be A1C. So I brought in all patients of all genders and all races. So when I look at the table, I wanted to have the patient's medical record number, their name, their date of birth, who they see as their primary care provider, when their last appointment was, and when they're scheduled for their next appointment. Also, when I pulled in the lab filter, I wanted a numeric number, which would, I'm hoping to be greater than 9, and when that was. This number also here helped later when I did the A1Cs that were not in the current year, because this would tell me when the last A1C was done. And if it wasn't in the current year, I would know. So this is what my report looks like within the system. I was able to pull in the MRN. I did take out the patient's name and date of birth for the safety and security of the patient, but this is kind of gives you some information what I was looking at. It shows the primary care provider, when their last appointment was, when and if they're scheduled for another appointment, when their A1C was, and then what their A1C is. So thankfully, my program worked out well, and I was able to pull in all patients who have an A1C greater than 9. As you can see on this list, there is not an A1C that is less than 9%. Also, you can see here that there's patients that do not have scheduled follow-up. If you remember back to my previous slides that I said 28 to 55% of patients in primary care do not have a documented follow-up. As you can see here, unfortunately, this practice falls in the higher end of that. There's lots of patients who do not have current follow-up. And unfortunately, some of these, such as a 3.2, does not have a current follow-up. That can be some little bit of concerning for this practice. When I worked with the IT department, I built the J Drive, which is this communal folder, which was for the care management team. I was able to put the program and the spreadsheet into this folder that allowed multiple members to use it. So this is just kind of showing you where this went. This is a communal folder to allow many members to use this and access this report. So what did we find? We found that 359% of the patients in the practice have an A1C of greater than 9%. During the time that I applied this and was doing my research, we were able to start self-management support on 26 of those patients, which means that our case manager or pharmacist team were able to contact these patients and start working with them. On the other end, we did notice that 186 patients within the practice who have diabetes did not have a current A1C in the current calendar year. During the time of my implementation of this, we were able to send out 35 letters to those patients that did not have a current A1C, and we did find that 4 patients did transfer out of the practice. Since then, we have continued to work this. Just because my research for my project was done did not mean we stopped using this. We did find that many of the patients that had an A1C that was not current in the year was seeing somebody such as endocrinology or another specialist that they had an A1C done at that office. We then had to manually enter those A1Cs into our electronic medical record to be able to update the information. We did not have that information. So since then, we have been able to find the A1C on probably more than half of the 186 patients. We have reached out and made some type of contact, either through phone communication or letter, to the rest of the patients who have not had a hemoglobin A1C. And the goal would be to continue to work with the patients, the 359 patients, to get them in care management to be able to lower that A1C. After we finished the dashboard, I asked for an evaluation by the medical professionals that use this with me. So I gave a survey to the medical doctor, a nurse practitioner, a staff nurse, a care manager, and the pharmacist to see what their thoughts were on the information that was received or how they use the dashboard. I'm going to show you the results that came from that survey. So one of the questions that I asked was rate the ease of use of the survey of the dashboard or the Excel spreadsheet that they used. So I asked 5 of them, and I asked them to rate on a scale from 0 to 4. 0 being they were unable to use it, the information was not useful to them, or 4 being it was very easy to use, and they were able to use the information. So one person said that that it was a 3 out of 4, and the rest of them said that it was a 4 out of 4 of the ease of use. I then asked them to rate the accuracy of information, 0 being the information was completely not accurate, that they found that the patients maybe had either a different A1C or they were lower, or that they did have an A1C and the computer did not, in the dashboard did not pick it up. Or it was very accurate and I wanted them to rate it a 4. So 3 of them said 3 out of 4 and 2 of them said 4 out of 4. I went to the 3 that said that it was only 3 out of 4 and I asked them what their concerns were. And they said that, when the information was not in there from the endocrinologist or the specialist that provided them inaccurate information. They were calling these patients, telling them that they didn't have an A1C and they did. So to them, it was more work because the information was inaccurate. And I agree, we were able to fix that in the long run. I then asked, would you use this dashboard again? And the 0 being no, they would absolutely not. And 4 being yes, they would. And all 5 of them answered yes, they would use the dashboard for their information again. I then asked, were you able to access the dashboard and the information? And were you able to use the information that was given? And all 5 of them stated yes, they were able to access the information. And yes, they used the information that was given. I then asked an open-ended question of how did you use the information that was given? And this is how it was broken down between the providers. The medical doctor stated that he used it for pre-work for his appointments, didn't really get into any more detail, but just said he used it for pre-work. The nurse practitioner stated that she reviewed these before her appointments to check if patients needed lab results that needed to be completed during their visit. The pharmacist said that she reviewed the medication of the patients with the highest A1C to see if the medications that could be changed to assist lowering in their A1C. The care manager stated that she started with the highest A1Cs as well to be able to contact them and enroll them into a program of self-management support to help lower their A1C. The staff nurse used the other information and she contacted the patients who did not have an A1C in the current year, or reviewed the charts of the patients. She was more in charge of getting the information from either the specialist or getting these patients into the office. This slide shows the program outcome of I5 quality improvement, I1 professionalism, and I2 patient-centered care. So the implications of the dashboard. The medical provider is able to use the information to monitor A1Cs, use it in his pre-work to see if the patients need blood work and what other information he needs for them. The nursing team is able to close the care gaps and receive and review specialty notes to find A1Cs from other providers. The care management team provided support in A1C monitoring of these patients, and the pharmacist is able to evaluate medical lists and provide recommendations for medication changes. One of the other questions that I asked in my survey was, what kind of recommendations do you request for the next outcome of the dashboard? The care management team was very big on this, that in our medical record, in our electronic medical record, we're able to order care management orders. This allows everybody to know if the patient is under their care. The care management team would ask that we then put in a filter to allow those orders of care management to be brought in, so they already know who they're working with and who they're not, so that when they're not overworking these patients, they're able to filter out the patients who are currently not receiving their care. They can also put in a patient is declining care management, so then they don't try to reach out to those patients again. So they're hoping that in the next wave of the filter of the dashboard that we can add a column for care management orders that are in the EMR. Another recommendation was brought up was maybe we should look at a different A1C. 359 patients of an A1C greater than 9 can be a little tough for the care manager and the pharmacist to work with in the beginning. So we thought maybe we should change it to 12, maybe 11, start with a smaller group of people first, get them under control a little bit better, and then we can lower that A1C down back to 9 and then get the people in between 11 and 9. But we think that maybe if we start with a little bit of a lower, smaller population of a higher A1C and get them under control first, that we'd be able to use our resources better. And that is my presentation on the dashboard I built for diabetic patients within our primary care practice. Is there any questions?
Tanya, this is Evelyn. And hi. I really I've liked this because it pulls it all together for me. And, not being an informaticist. And I'm sure I told you that several times. Uh, it's nice to see how it all came together. And I
Thank you.
think it was a good job.
Thank
And
you.
I wish you the best as you continue to work with your dashboard.
Thank you.
Um, Good job.
Thank you.
Wonderful, wonderful presentation. We haven't had a lot of informatics presentation, and as Evelyn said, it's nice to see these and see what students can do with them. Your slides were good. You had some appropriate data. You didn't try to do a lot of heavy research. Certainly my husband's a type 2 insulin dependent diabetic, so it's like a really big deal, right, to track them wherever he goes. Where do you see this going next? What are you doing next?
Well, we've used this dashboard in more than just our diabetic patients. One of the things, especially with COVID, that we've done with this is we've able to see who we're seeing telemedicine wise and who we're seeing in the office to kind of get it to give us some more information. So diabetic wise, my goal is to hopefully lower that number from 359 to definitely a smaller number and be able to monitor those 189 patients who are not getting their A1Cs done and definitely, control them a little bit better. But my goal with this is to not only use it for diabetic patients, but maybe spread out. Like I said, we're using it to use the information to filter patients who have been seen in the practice and then looking with, telemedicine versus in office. And in here in New York, we have, some capitation plans. So are we seeing more capitated patients who are being telemedicine? So we're kind of using this dashboard in other ways besides diabetic patients to kind of see who's coming into the office. So I've been able to filter data a little bit differently each time. So
Yeah, and I see this just as your beta early prototype version, and I'd be curious to see where it is 5 years from now, probably being bought, making you rich by Epic or Cerner, right? Good job.
thank you.
Hi, this is Pat. What led you to choose the A1C as your first foray into this building the dashboard?
Actually, a lot of governmental programs kind of led it that way. We deal a lot with CMS and NCQA in our alphabet soup of regulations. And one of the ones that we look at is they want our A1Cs below 9, and that we get a lot of information from NCQA because we're certified for NCQA here in New York. And they want us to show that we're monitoring and lowering our A1Cs. And they've chose 9. So I know for us that 9 is a big number, but again, 359 people is a lot of people to get below 9. So like I said, our recommendations maybe start a little bit higher than 9. But the reason I chose A1C as our separation is due to NCQA and CMS and trying to follow those regulations a little bit better.
Yeah. It's fascinating. Are there other parameters that you think that you can add to this to measure with this that would help your whole care management team?
Absolutely.
Recommendations were?
Yeah, one of the things that I've thought about personally, what are recommendations is, like I was saying, a lot of our EMRs, and you guys, we can order a lot of different things. So with diabetics, especially, we need A1Cs, we need eye exams, we need microalbumins. So eventually my goal is to add that information in there too. Which patients have not had their microalbumins checked this year? Which patients have not had their eye exams done, because those are also part of CMS that we need to in our HEDIS measures. So eventually, adding more information of those specialists in those other testing that the patients need throughout the year, to add that into the dashboard as well.
To give the total picture of the patient. Then.
They may have their hemoglobin A1C done, but maybe haven't seen an IE specialist in 6 years, and we need to get them in there. So they may be, compliant in one, but not the other. So,
or the A1C might be they might have been able to work on it to get it down into a quote normal range, but they're out of compliance with other issues,
And
you
it
know,
makes,
in your,
especially with
go ahead.
with microalbumins, maybe their A1C, we finally got it down, but for so long it was high that their A1, their, microalbumin's abnormal. And then we have to put them on a different medication or something to protect the kidney. So there's a lot of information that could be pulled into this. Absolutely.
Great job.
Thank you.
Well, I just want to say that I think it's so exciting to see how many hours, days, weeks, months of work you've put into this. And it's not just a project to get you through school. This is something that can be used to increase the efficiency, the effectiveness, and the safety of patient care. So that's really exciting. And I agree with Cheryl. I'd love to see where you take this, because I think it's just wide open for you. And so that's very exciting. The implications I thought were interesting, and I like that people were giving you, let's change this, how about this? I think every dashboard I've ever worked with, there is that continual morphing toward a better product. And so that's just, that's a blessing that people are giving you some feedback that probably will take this to the next level that you're going. So I had some questions written down, but you were so thorough in your explanation. You answered everything before I got them. So got to ask them. So I appreciate that. The only, I think, hint I would like to give you when you do a presentation, a formal presentation like this, and you're going to have opportunities to do this again, and that would be to include the citations for the references of where you got certain information that was not generated by this project. In other words, there were some very interesting percentages about different things. And I think it just would have put a little polish on it to go ahead and include those citations and a reference of where that came from. But other than that, I thoroughly enjoyed it. Congratulations. You're going to do something big, and we're real proud of you. Thank you.
Thank you.
Okay, well, thank you so much for coming, and Tanya, you did it.
Congratulations, Tanya.
Thank you.
Yes, yes, absolutely.
Congratulations.
Thank you.
There was, that 8 weeks was a long work time.
So, do you have any other questions for us, Tanya, about anything, or because I think you're all set to go. We're gonna meet after you go ahead and leave and remake me host. We'll go ahead and talk about your presentation and score your presentation. Oh, good. There it is. Am I host now?
Let me see.
Not yet, huh?
Not yet.
And yeah, and then do I stop the recording? Can I stop? No, you have to restop the recording. Sorry. So
That's
you
all
have to read.
You can if she gives control back to you.
Okay, can
Call
I?
back to you, so I think you can stop it now.
Okay, very good. So I'll be talking with you a little bit later on today.
Okay.
And in the meantime, excellent job.
Thank you.
Really happy for you.
Mhm.
Thank you. And thank you, Mary Beth,
Thank
especially.
you. Thank you for the opportunity. It's been an absolute pleasure working with Tanya. It's funny, you know the saying, how things are meant to be and you're always put in the place you need to be at the right time. So, you know, when COVID put a squash on Tanya's experience in the spring and we had to pause, it was really a good thing because we've picked up our EPIC project at work, and just amazingly, Tanya and I have been working on dashboards for the last, well, all of her 64 plus hours that she's spent with me. So it just took this capstone project and took it to another level. It was just perfect.
It was.
Well, thank you all. So Tanya, I'm going to go ahead and say that I'll see you in just a little bit.
All right.
Okay,
Sounds good.
thank you so much.
Bye.
Okay,
Bye.
bye everybody.
Bye, everybody.
Bye.
Okay, stop recording.